All right, welcome everyone. Thank you for joining us for this very exciting BrainX Community Live event for October 2023. We have two very exciting speakers, Dr. Berk Ozmen and Dr. Hasan Cetin, both of them clinicians, but postdocs integrating deep learning to healthcare. So a very exciting session, having some young enthusiastic physicians taking a deep dive into deep learning. For those of us or you who are joining for the first time, we created BrainX Community 5+ years ago. That's the picture from our very first meeting. We have had 5 very successful years. We have 5,000 plus international member community now. Our LinkedIn group, which itself has 2,600 plus members, is a very active group sharing scientific information and collaboration opportunities for application of AI in healthcare. And of course, our website, which I'll go through, will show you, has a lot of content that is free and available to you for your journey related to AI and healthcare. And of course, we do these monthly live sessions over here to benefit everyone, not just clinicians, but also the AI experts, anybody else who's interested in applying AI to healthcare. Again, this is our website. It has a lot of different resources. Our homepage, you can go there and you can get the constant updates there. We have the Connect section where there is information posted about these live sessions, which links you to the past sessions, which is on our YouTube channel. So don't forget to subscribe to our YouTube channel called BrainX Community so that you can get the latest recording directly to your email. As I said, a very active LinkedIn group, now 2,600 plus members, almost touching 2,700, and a lot of scientific information flowing through this channel. These days, you have to leverage social media to stay active, and that's where you can go, become a member, and get all your information. We have our Learn section, which has curated list of articles, journals, books, and courses related to AI and healthcare. They are linked because we cannot provide you the articles directly. So you can just click on those links and go to those articles, and they're categorized. There is a filter option, so you can filter them for your favorite healthcare specialty. Like today, it's ophthalmology and plastic surgery as case in point. Interestingly, we also added a LLM filter this time. So you can look for the latest large language model publications that are of significance and importance by directly applying that filter. Of course, everybody is looking for data, especially in this new world where large language models and foundation models are proliferating. You want to get hands on the data. We have the largest repository of links to open source healthcare datasets, 160 plus links available directly through our website. Go over there. Again, you can filter it by the topic. And now we did add a LLM section because there are some LLM data sets that are available. So go check those out. We have our podcast series, which features some of the very experienced, some of the very proficient people applying AI to healthcare. So you can listen to their journey, you can listen to their experience, you can hear about what their vision for the future is. So please subscribe to BrainX Talks. It's our podcast series, and you can listen to it on your favorite podcast channel. Meetings and conferences are back after COVID-19 in person. So you can go to our meetings and conferences section on our homepage, and you can find the best opportunity to connect or showcase your work. That brings us to today's event, which is deep learning applications in ophthalmology and surgery, two very smart speakers. And as you can see, this graph represents number of publications that are growing exponentially in this space. So both ophthalmology and surgery, they are leading some of the work applying deep learning to the space. Amazing speakers, and thrilled to have them here, both of them doing a postdoc at the Cleveland Clinic. So very excited to see how they are bringing in energy to this space. And with that, I'm going to transfer it to Dr. Hasan Cetin and welcome him to give his talk.
Thank you so much, Dr. Matur. Welcome, everyone. Thank you for joining here us with today. So Before I start my presentation, let me give you a quick introduction for myself. My name is Hasan, originally from Turkey, and working as a postdoc since 2020 in Clinical Eye Institute with Dr. Justice Adlers. Our lab is focused on ophthalmic imaging techniques and medical image segmentation. So today's my presentation will be about deep learning in retinal imaging and biomarker development and prediction of disease progression. So welcome again, and thank you for joining. So let's start with what is optical coherence tomography, what is OCT. OCT is basically a tool that led us to take a look at the behind the eye, the retina and the optical nerve, and why this is important for us, why OCT is important for the ophthalmic area. First of all, it is a non-invasive procedure. You can think it like an ultrasound, but rather than using sound waves, we are using a laser, we are using photons, lights. And as I said before, it is a non-invasive technology, and it takes usually a few minutes to take a one scan. And within this few minutes, after this few minutes, we will have OCT scans. So we can use those scans to assess the diseases, ophthalmic diseases, and basically we can decide whether this patient needs to be treatment or not, or disease is progressing or not. But the caveat here is the one OCT scan usually has more than 120 slices. So assessing those scans can be time consuming. In order to prevent this time consumption, it's a labor intensive procedure. So why image segmentation is important here? As I said before, with the help of the deep learning algorithms, machine learning algorithms, we can segment those layers, we can segment those retinal layers, and we can have some calculations, we can have the measurements, and we can decrease this labor intensive process. So how are we going to train a machine learning model? In this slide, I put only one part of it. It's a unit architecture. So we can also use other approaches as well. But first of all, no matter what we are going to train, we need some ground truth images. We need some segmented images. So once we have the segmented medical or OCT images, we can start training model. We usually do unit and transformer models, but as I said before, we can use other approaches as well. Once we have the model, it now becomes to how can we use those models? We can easily use those models to, get some basic calculations. But at the same time, we can use those models to detect other pathologies. In this project, geographic atrophy detection project, we wanted to create a model, train a model to detect the geographic atrophy areas. So what is geographic atrophy and why this is important for us? You see the here in the second image, you see the areas that are marked yellow, marked green. Those areas represent the geographic atrophy areas, which is basically means dead areas in the retinal tissue. So once the geographic area occurs, basically it means that there is no FDA approved treatment right now. So And this disease, especially AMD, we are calling it age-related macular degeneration, is important for age 55 plus people, because at the end of this disease, people are basically becomes blind. So this is one of our papers, and again, we decide to train a model to detect the geographic atrophy areas. We did train a UNet model with more than 100,000 OCT B scans. So first of all, we basically segmented those scans manually, and with the help of those masks, we did train models. We did train two different models. First model was trained for the B scans, and the second model is trained for the on-phase images. With on-phase images, you see the on the right-hand side of the image, you see we are stacking those B scans on top of each other, and we are creating the on-phase images. And the results is the following. You see F1 score for the B scan model was 0.87, while the sensitivity is 86% and specificity is 94%. And the prediction of the pixel-wise area measurement of GA was correlating the ground truth GA area. You see how the model performance here. Green areas represents the prediction. Green areas represents the GA areas that are marked by our model, while the blue areas represents the ground truth, and the orange areas represents the false negatives. And for the on-phase model, you see the green areas, again, the ground truth, and blue areas, apologies, green areas are the machine learning model results, while the blue areas are the ground truth. You see, again, this one is also aligned well with the ground truth GA area. And the other project that we were working on was the hypertransmission model. So what we did here, since we had an ability to detect the GA areas, we thought that, okay, how can we predict the GA areas, the future GA areas, right? As you can see here in the image, you see under the GA areas, in the choroidal area, we can see a hypertransmission defect. So we thought that, okay, if we can detect the hypertransmission areas, we can also predict the future GA areas. But we didn't want to segment those hypertransmission areas from scratch. So we decided to increase the thickness of the previously segmented GA areas. And basically, we aligned those hypertransmission areas. So we did train two different models. Why? Because most of the ophthalmic imaging centers are using two different machines. One is Spectralis and the other is Sirius. Why did we decide to choose this approach? Because we know that if we can specify as much as we can increase the model performance. So we did train two different models, device-specific models, and we did use more than 30 million unit parameters to train those models. Again, for each model we did use almost 100,000 images. And those are the results. So you see here is the red areas represents the models performance. So areas are marked in red, detected by the model, and marked as hypertransmission areas. And you see the ground truth, the GA areas is marked as orange. So in other words, our model had a contextual idea, knowledge, and it learned where to look at it. It learned more than what we give. And you see the results here. So those are the unfuzz images on the right-hand side. You see the unfuzz model is pretty doing not a great job in a images with low quality images, right? You see that here in the first row image, you see those black areas in the hypertransmission defect. Those areas are normally hypertransmission areas in the B scans, but the thing is that the tissue in the retina is so atrophied, so we can see the choroidal vessels underneath. And the unfuzz model thinks that those areas shouldn't be hypertransmission areas, and it causes some false negatives. But in the contrary, B-scan model knew that those areas are hypertransmission areas. And you see the R-square values on the left-hand side of the slide. So to predict the future GA, unfuzz model is doing a better job to predict the near future, while the B-scan model is doing a better job to predict the distant future. For the future work that we decide, we are trying to use the hypertransmission model. How are we going to do that? You see that those hypertransmission defects are the GA areas in the unfuzz images. So if we subtract the GA areas from the hypertransmission areas, we will end up having an edges of the GAs, which we think that GA lesion will grow up on those edges. So on the latest image, you see how it aligns with the model results. So the green areas represents the ground truth, represents the real GA growth areas, while the yellow areas represents how it overlaps with the hypertransmission model results, and the red areas represents the false positive. So again, this also showed us that hypertransmission can be used as a biomarker to predict the future GA, right? And we are going to continue work on it, and hopefully we will get a better results. Since it's still in a project, we are working on it, and we will share the results. We will share more extensive results pretty soon. And thank you so much for everyone for giving me the opportunity to share my work. Thank you.
Thank you, Dr. Cetin. That was pretty interesting work, and we will take questions at the end for you. So if you don't mind staying by.
Sure.
And not many people know, so I'm an anesthesiologist and IC physician, but when I was at med school, I was debating whether I should be an ophthalmologist or not, or an eye surgeon or not. So I was very close to getting into it. It was one of my favorite fields. So it takes me back to good old days of med school, where we're doing all this exciting OCT and retinal exams. So thank you for the great work and exciting presentation.
Sure. Well, thank you so much.
With that, I'm going to invite Dr. Berk Ozmen to talk about the next thing. So beauty lies in the eyes of the beholder, and for a plastic surgeon, how do you apply deep learning to plastic surgery? So Dr. Ozmen.
Thank you, Dr. Mater, for the invitation. Let me quickly share my screen. Okay, are you able to see my
Yes.
First slide. Okay. Again, thank you so much, Dr. Meter. This is wonderful to be here with you. I've been following the BrainX community for some time now and really learned a lot along the way. There has always been very great speakers, very great discussions, and it's such a very helpful community to learn and be more involved in artificial intelligence in medicine and surgery. I'm a postdoctoral research fellow in plastic surgery department in Cleveland Clinic. I work with my dear mentor, Dr. Graham Schwartz, and I'll be talking about artificial intelligence and deep learning in plastic surgery today. I have no disclosures. The agenda for today, I'll briefly start with an introduction and then talk a bit about deep learning models, deep learning in medicine, what's currently applied to, the future trends and opportunities, the challenges and limitations that needs to be overcome, the currently available literature in plastic surgery, and we will conclude. Introduction, as you know, deep learning is a subset of machine learning with very robust AI models. It has been proven to be very effective in various tasks, image and speech recognition, natural language processing, and many more are currently applied very successfully across a wide variety of industries, from healthcare to automotive industry to many other industries. And it's much more in our daily lives now. So deep learning models, we have the convolutional neural networks that it works very well for computer vision. Recurrent neural networks are very good for sequential data. Generative adversarial networks are so good for synthetic data generation, and there's much more going on in the field. One of the fueling powers of deep learning and AI is open source development. And this is a section from Hugging Face, which is an open source developers base. And you see there are like various models. The multimodal models are the next big thing now. I see them as a very important player in the near future, especially for healthcare applications. We see a lot of models in the computer vision section, many models in natural language processing, audio, and many for tabular data. So deep learning in medicine, we have seen quite few very good examples, from imaging diagnostics to treatment planning. There are very good examples in preoperative planning, intraoperative decision support, post-op complication prediction, drug discovery, and genetics analysis. Regarding the future trends and opportunities, and especially for plastic surgery, AR, VR, MR, these are very good, very promising technologies, and these will help with pre-op planning and training, and we will probably need a lot of AI models to help us bring these technologies more forward. And robotics is getting bigger day by day, especially with the recent microsurgery and super microsurgery robots. The AI models will for sure play a good role in those as well. Possible integration with other AI models. Large language models are driving the force here. I envision a future of a confluence of technologies, especially in the operating room. You'll have a large language model specifically trained for surgical procedures, and then you'll get probably some real-time decision support, risk optimization tools, and these will all work together in the operating room. And for federated learning is a very promising concept, especially for adoption for big data sets. We need very big data sets to train robust AI models. And one of the challenges that needs to be meticulously and carefully be overcome is HIPAA limitations, and federated learning will be a good one for that. And moving on, we will have probably in the near future some predictive models integrated to our EHR systems. These will let us have real-time access to AI models and global access for remote consultation and surgical procedures. There's a lot of development in Da Vinci surgical consoles that have led to remote surgical operations, and we may be able to see that in the future of plastic surgery, and AI models will for sure help us in that way. Learning curve. My special take on this is that anything that there's a learning curve in medicine and surgery, AI models may help and probably will be pillars of education in the future. And then they will also help for decision support, especially for early young trainees. And then we have recently seen a very good surge of papers and training and education tools with large language models, especially with the recent adoption of ChatGPT. Moving to challenges and limitations, data privacy and security is a very important one. Everything needs to be HIPAA compliant. There are some technical challenges when it comes to healthcare. So we need big labeled data sets, but that may require multi-institutional collaborations. If the data sets are small, then there are overfitting issues, and the algorithms need to be prepared carefully. For any innovation needs clinical validation and essential rigorous testing, clinical trials, and FDA approvals, and AI models, and the developments that we'll be shortly talking about in the subsequent papers. We'll also need to go through that route to be ready for use in clinical environments. There's also some ethical considerations that needs to be addressed carefully. There may be bias in algorithms due to data. They need to be transparent, and these are all important limitations. So we'll shortly be reviewing some papers. These will not be only for deep learning, but also artificial intelligence and machine learning, especially in plastic surgery. So this one is a very good paper that we also talked about in our journal club. So it is now it's possible to work with computer vision, get pre-op images, post-op images, analyze the effect of some surgical procedures. In this one, the authors decided to work on estimating apparent age with AI after a certain surgical procedure, a blepharoplasty procedure. Their model worked very well in terms of predicting. They used a convolutional neural network. They did very good data augmentation methods, and they had a very good data set in terms of numbers. And this is a very good paper that shows us that these models can be applied to any surgical procedure that has similar data sets, and that these certain outcomes may be of interest. Another paper, we're seeing a patient monitoring tool. The authors here did a study on reliability of post-op free flap monitoring with a novel prediction model based on a supervised machine learning algorithm. these tools will probably be much more in our daily lives in the near future in the clinical environment, and they showed a very good reliability. And of course, these would need to go through all the FDA approval procedures, but these are very, very promising developments in this space. Another one within this regard, another flap monitoring tool. This one is also recently published, a quantization of extraoral free flap monitoring for venous congestion with deep learning integrated iOS applications on smartphones, a diagnostic study. This also shows us that we'll have more wearable devices or mobile devices all integrated in the patient care in a more wide setting with the help of AI. We're seeing a very good study here. The authors here worked on to develop and validate the deep learning model using convolutional neural networks to identify scaphoid fractures in radiographs. We have seen similar studies, especially in radiology field, regarding the use of CNNs to identify fractures, to identify other areas of interest. And this is a very, very well done study with a good number of radiographs. We're seeing above 11,000 radiographs, and this study is a very good study. This is also a follow-up study of the previous paper. They validated clinically in the same model, and the results are very, very good. Open source development is very important for development of AI, and we're now seeing an open source 3D morphing software for facial plastic surgery and facial landmark detection research, an open access face data set based on deep learning generated synthetic 3D models. Synthetic 3D models and synthetic data has recently been on the rise. I'm pretty optimistic that we will see more examples of synthetic data sets, synthetic data models regarding digital twinning, and within that regard, there is a very good use of synthetic data sets to simulate different clinical scenarios. ChatGPT and large language models has been really popular, and there's a lot of recent papers. One of them is here. The title says "Consulting the Digital Doctor: Google versus ChatGPT as Sources of Information on Breast Implant Associated Anaplastic Large Cell Lymphoma and Breast Implant Illness." We have some other ChatGPT studies here as well. They applied GPT-4 to the plastic surgery in-service training examination. These papers are open to a lot of discussion because we're sure whether OpenAI trained GPT models with these data sets, these clinical data sets. Somehow they're performing pretty exceptional, but I'm sure in the near future we'll have our own large language models developed with specific data sets. Again, this is a similar paper, but also including the computer vision models such as DALL-E, Midjourney, and Blue Willow, and they also use generative AI for cosmetic surgery here in this context. One of the important areas is computer-aided diagnosis, and we're seeing a very good example here, computer-aided diagnosis for screening of lower extremity lymphedema in pelvic computed tomography images using deep learning. These also require validation studies, external validations, but very, very good examples that kind of show us where the future is headed. Again, preoperative planning is will probably benefit a lot from AI and deep learning. Now we're seeing a transforming breast reconstruction, the pioneering role of artificial intelligence in preoperative planning titled paper, and these algorithms have a lot of use cases to predict complications prior and develop a plan regarding that. So in conclusion, there's many use cases of AI, machine learning, and deep learning in plastic surgery, and exciting innovations ahead. I'll be happy to take any questions that you may have, and thank you so much again for inviting me.
Thank you, Dr. Ozmen. That was pretty inspiring, and it was good to review some of the publications related to plastic surgery. I think a lot of lessons to be learned from the R&D that has gone over there. I do see one question over here from Jackson KC, and that's for you, Dr. Ozmen. What is the best thing to look for when your training accuracy is good, but validation and testing accuracy is not as expected? So your training accuracy looks pretty good, but when you go to testing and then validation of that, it drops. We find that not uncommonly. That's a common problem that we see. And then what aspects of fine tuning do we need to consider? Any specific hyperparameters that you can think of? And Dr. Cetin, feel free to chime in too. So we'll start with Dr. Ozmen, and then we can go to you, Dr. Cetin. What's been your experience there?
So data set is very important. We need big data sets for these robust algorithms to train on. Maybe playing with the data set in a way to better optimize the numbers may help.
All right, Dr. Cetin, any thoughts on that? What's been your experience with this problem?
Sure. Well, as everyone said, AI is still a black box for us. So for the hyperparameter tuning, I will go with random different parameters. It will be case specific, but if we are having a problem with the class imbalance, I will try to increase the data set size with synthetic data. Like we have some cool algorithms such as smooth and other algorithms like that. They're pretty useful in increasing the data set size, and sometimes they can be useful to increase the model performance as well. And as I mentioned before, I will say to increase the performance of the model, especially if we are seeing a bad performance in a test set. I will take a look at the training process first, like what we did wrong, because obviously something is not correct, and model is having a hard time with deciding or whatever is the duty is in real world data. So I will maybe change the data set structure. I will add or decrease the parameter numbers. We can I don't think that there is a one correct answer for this question. It's open to explore. We definitely need more. We need more experiments in terms of to get the best results.
Yeah, I agree with you. I don't think there is one answer to addressing this, but it's not an uncommon problem. You look at the data. You need to see like if it's an issue with the data. You need to. I would even take a step back. Like many times, of course, we just the two different presentations in context was mostly around convolutional neural network, but many of the other AI research and development work may not be using convolutional neural network. So you might have an opportunity to even look at a different model instead of the model that you're currently using. I would just take a 30,000 feet viewpoint, see like maybe this is not the best model that we're applying before you even go to the hyperparameter or fine-tuning aspects of different things. So data, that, and then the different parameters as you said. Now, one thing that I saw common in both the presentations was it's very heavily dependent on convolutional neural networks, right? Because it's all image based, both in the ophthalmology space and in the plastic surgery space. And with the disruption coming in with the foundation models, which is very, very exciting, where we are seeing multimodal approaches to this. Where do you see things going in your world with that? Because we have done a lot with playing with static images and with convolutional neural network. I think that has become a child's play in many ways. So where do you see the world going in the future? So we'll start with Dr. Cetin, and then we'll go to Dr. Ozmen.
Yeah. Well, I will say that we are in the midst of the revolution, AI revolution. There's definitely a hype around the AI, machine learning stuff in anyone. So, but still, it's open to explore. Like most of the industry leaders, technology companies are investing a lot. And we have some challenges like, okay, we are able to train models, but are those models are clinically relevant for our problems? Like, okay, do I really care a few micro differences in retinal thickness in clinical stage? So maybe my F1 score after training is I'm having a low scores, but does this means that model is performs bad? Does it acceptable in the clinical stages? That kind of problems needs to be addressed, and there are some regulatory problems as well. So how can we protect the patient's data information? Because we know that to train those models, we need data. We need more data. And how is the regulatory processes will develop? That kind of problems needs to be addressed. And one other thing I would add that there are some limitations in terms of how to apply. Like, okay, I have the model, but do I really need to some kind of spaceship GPUs to get the results? Can we use cloud instead of local results? So that kind of things to be addressed. And again, we are still in the, I believe, beginning of this revolution. We have too many questions to ask, too many answers needs to be found. So those are my thoughts on AI in medical settings. Yeah.
Dr. Ozmen, your thoughts?
I think multimodal models is the way to lead the future in healthcare. So what my take on this is that these models need to be mimicking physicians' decision-making process in a way to give correct decisions, right? So if a physician is making a decision regarding the clinical text data and the imaging data, then a multimodal model that blends both of these inputs would be very helpful for correct clinical implementations. However, but as Hasan said, Dr. Cetin said, it is very, very important to have big data sets to reach that level.
Yeah, there is another question in the chat over here from Jackson again, and I think it connects with the examples that you showcased. Most of those were around diagnosis and prediction, and the question over here is about is the role of deep learning primarily in just diagnosis and prediction, or do they have, or I should say, in prediction and detection, or can they help make diagnosis and therapeutic advice as well? So what's your take on that? I'm going to start with Dr. Ozmen and then go to Dr. Cetin.
Yes, there's endless possible use cases. Even I have seen a presentation here some months ago, if I'm not mistaken, that was on drug discovery. Right? There are very, very robust AI models that are being trained on vast amount of literature to find connections between diseases, right? And so the possibilities are endless. It's just not just for diagnosis and predictive models, but it could be used for education, training, simulation, simulating different clinical scenarios, digital twinning. There will be tons of possible use cases. And also, as I stated numerous times during my presentation, possible different integration with other technologies is very important, such as AR, VR, MR, other robotic surgical technologies, other devices and technologies that goes in healthcare, and their interplay is also very important to optimize their process, to get better efficiency, faster, and in a better way.
Dr. Chetan, you are on mute.
Apologies. Yeah, I agree with Dr. Ozmen. For the treatment part, I believe that AI will help us to treatment in most any case. You can imagine, like, okay, as a physicians, we are really good at diagnosing. That's I don't see that as a big problem, but I believe that the problem here is with late diagnosis. So it's okay, I can see a chest radiograph and say that, okay, this guy has a pneumothorax, right? But can I predict that pneumothorax before it happens? Or in an ICU setting, okay, I can see that a person has some weird electrolyte imbalance, but can I predict that person will have electrolyte imbalance before it happens? So that kind of prediction algorithms will help us to provide better patient care, I believe, in the future. As I showed in my presentation, GA is the end stage of the disease, and you cannot turn those tissues back alive before it. We need to do it before it happens. I don't see any reason to trying to turn that tissue alive. We have to prevent this before it happening. Like, can I use, I don't know, maybe a complement inhibitor to prevent this inflammation occurs? Or if I can do that, which patients needs to get those inhibitors? So that kind of questions can be easily answered with the help of AI, I believe.
Yeah, I think it's being applied in all different phases of healthcare. So, and that is very exciting to see. I think there are a couple of other questions, but I'm going to try to put them together, and especially with both of you as postdocs, it's more about the approach. So one of the questions is about, like, how do you pick and choose the model? You just take an existing model and you modify it for your use, or do you start from scratch? Like, what's your approach to that? And then again, a question which relates to the the performance. So if you get stuck with a low performance, what's your approach to trying to improve the performance of the model? So how do you pick a model, and should you just take something and then customize it for your use, or start from scratch? And then if you're struggling, so it's more about the approach and your strategy about how do you go about it. So what have you seen and what are your thoughts?
Yeah, sure. I would say that there is no need to invent a wheel again, right? And it's all depends on how much time, how much money you want to invest for the solution. So if you don't have a big data set, you can use a foundation model, and with the help of the, I don't know, maybe a transfer learning algorithms, you can make that model better. So if I don't have a big data set to train a large language model, why would I start from scratch and get some bad results? I can use a foundation model. I can fine tune it with my own needs, and I can get better results. At the same time, if I have enough data set, I can start from scratch, and maybe I can outperform the current previous models as well. So I believe it's a case-specific case-specific answer, and it needs to be tailored on person's needs. So it's also about the problem as well. So sometimes for the rare diseases, I would say we don't have enough data. We don't have enough real world data. We can use maybe, I don't know, maybe one-shot encodings, things like that. So it's all case-specific answers. And for the training, for the what model, how can we improve the performance? Again, I will say experiment. We have to try over and over again, because it is still a black box. We don't know what is happening inside of this box. We know that garbage in, garbage out, but sometimes even with a good data set, we can get bad results. So we need to do more experiments.
Yeah, it's all, and that's part of the reason why we do this BrainX Community sessions, because sometimes you're just doing cardiology-based research, and you're missing out on what other streams are doing and ordering. So you think about like application of convolutional neural network for image analysis. It's big leader is radiology, so we have them come and present, and maybe ophthalmology can learn from the techniques, or plastic surgery can learn from the techniques, or general AI researchers can learn from these. So that's a big purpose of doing this session, that how can we use these combined learnings, and that's a big part of our BrainX AI research group, where we look at how can we learn from each other and expedite this. And we see some of the evidence out there. Radiology are the front runners, but then we see gastroenterology or ophthalmology or plastic surgery trying to leapfrog, because they learned from the works of others and are applying that to their own field or their own problem. But I think it all boils down to start with the problem. That's what I put in the comments too. Start by defining the problem. The model is like a tool that you decide later, but start by defining your problem, your data set. How are you going to curate it? What do you need to be successful? I think that strategy is very, very important. Dr. Ozmen, your thoughts?
Yes, exactly. And in addition to both of your comments and answers, looking at prior like published research papers, the recent conference papers, the published research papers also help a lot in terms of seeing the current approach for similar problems and what other people did to overcome those problems, right? So that's also very important to build upon what others have already done and published and open source released to develop better models for better AI.
Yeah. And again, we are close to the end. So I want to thank both the presenters, and I want to thank all the audience for their amazing questions and their participation. Clearly, there is a lot of work need to be done, but You are true examples of leading this for a lot of us, and it truly inspires us to collaborate more, work more, and to the end, follow us on brainxai.org. Join us over there and get all the content for free. Join our LinkedIn group called BrainX Community. Join our live sessions where we can have a healthy exchange and learning. Follow our YouTube channel for the latest events that are recorded. Follow our podcast series so that we can learn from each other. And lastly, you can always connect with me and drop a line. Happy to work with you. So thank you everyone for joining us for this very exciting session. Until next time.